This is Marquel Thomas, and my topic for the week is epiglottitis and periorbital cellulitis. Epiglottitis occurs when there is swelling and inflammation of the epiglottitis and nearby structures. This condition is a life-threatening infection that produces intense swelling of the upper airways that leads to asphyxia and respiratory arrest. Edema of the epiglottis, the aeroepiglottic folds, and other adjoining tissues. Epiglottitis will result from S. pneumoniae, S. aureus, and beta hemolytic streptococcus. However, Haemophilus influenzae remains the most common pathogen in both adults and children. Infection of the epiglottis can lead to edema that is marked and swelling of the epiglottis and supraglottis and can affect clients of any age. The posterior nasopharynx is the chief source of pathogens. For hours to days, symptoms will be very mild. Then the symptoms will get worse dramatically. They will mimic a sudden onset. The client will present as being very uncomfortable and possibly overtoxic. Some children will have no symptoms. While in the emergency department, the child will be noted to be in an upright position with their mouth open in a tripod position. They will sound muffled and have some anxiety. It's also important to note the 3 Ds, which include drooling, dysphagia, and distress. Because the upper airway swells, this results in turbulent airflow, and you will note some stridor on inspiration. Some signs of severe upper airway obstruction include retractions, tachypnea, and cyanosis. You should also be on the lookout for respiratory failure, and this would prompt the clinician to act quickly. An oropharyngeal exam is usually not performed to evaluate a suspected case of epiglottitis because manipulation of the oral cavity may lead to respiratory arrest. So the diagnosis is primarily one of clinical suspicion. A lateral neck x-ray will show swelling of the epiglottitis, which will also be referred to as a thumb sign. This is not necessary to make a diagnosis, but can be used to narrow down the differential diagnosis. It is also important to avoid examining the throat with a tongue blade or laryngoscope because it can result in losing the airway. Securing the airway is the most important aspect. If the child is admitted to the hospital, keep a tracheostomy tray at the bedside. Corticosteroids may be used to reduce edema. Antimicrobials may be used empirically until results of the culture and sensitivity are made available. It is important to follow up and have consults with a pulmonologist, an ear, nose, and throat specialist, an infectious disease specialist, and an anesthesiologist. Periorbital cellulitis. Periorbital cellulitis is an infection of the skin and soft tissue surrounding the eye that is interior to the orbital septum, commonly seen in children, and is mainly caused by sinusitis and trauma. Again, this condition is very common in the pediatric population. The pathophysiology of periorbital cellulitis is commonly caused by Staphylococcus aureus, Streptococcus pneumoniae, and Streptococcus pyogenes. Some participating events of periorbital cellulitis are sinusitis, insect bites, impetigo, and facial trauma. The pathogens triggering sinusitis span to nearby tissues, causing this condition. It is important to perform a thorough history and physical exam with the client. The history will reveal some important information regarding If the client has had any kind of trauma, bitten by an insect, an infection, sinusitis, an upper respiratory infection from a nearby site, the client will present with arrhythmia, swelling of the eyelids, and edema. This condition has been associated with decreased vision, watery eyes, fever, injected conjunctiva, discharge, and chemosis. Because the clinical differences between periorbital and orbital cellulitis can be uncertain, radiology findings are important. A CT scan of the sinuses and orbits allows distinction of the two disorders. This is also a way to establish the degree of infection. With periorbital cellulitis, the CT scan will show swelling of the eyelid. A CBC and blood cultures are obtained only if the child is febrile. Treatment is based on how severe the disease is and the age of the child being treated. Children should be treated with antibiotics. For those children that are 1 year of age or older and have mild symptoms, they can be treated on an outpatient basis with oral antibiotics. For those children under 1 year of age and a more severe infection, they should be hospitalized. Treatment with antibiotics consists of clindamycin, Bactrim, Augmentin, and ceftriaxone. If there is no response to antibiotic treatment within 48 hours, then the child should be hospitalized. A CT scan should be obtained and a surgical consult should be done for incision and drainage. To assess response and toxicity, the client should be followed up within 24 hours. They should have daily visits until they are fully recovered. Anytime a client has an eye infection, they should be referred to the ophthalmologist. This condition will usually respond to treatment with antibiotics. The parent should be informed to return to the clinic if the infection does not get better.